Thank you for giving me the opportunity to talk a little bit more about criteria regarding the rest, except of outside epilepsy. So, I already told you that this study is about determining the most relevant outcome measures, and it makes sense after everything we heard this afternoon. So I will go quickly. It is obvious for everybody that it is necessary to identify objective, reliable, and sensitive outcome measure. And what is also very important is that it can quantify the core defects of the patients. And unfortunately, because of the severity of the cognitive impact, sometimes we cannot use some of the usual outcome measures. And of course, it has also to correlate with the quality of life and true functional improvement. So the objectives of this study was to determine the relevant endpoints to be used in future clinical trials, involving in terms of feasibility, ability to assess these patients despite their cognitive deficit. And you will see that a part of the patient participated also to a longitudinal study to have an idea of the variability of the design and of the outcome measures. So we did want also to assess the feasibility of a SCED design, single case experimental design, with repeated measures, including assessments at home on tablets. And the families that participated in the study knows that it was quite a challenge, but everything on my perspective, everything went smoothly, but they might disagree. We'll see with the questions. Then we would like to assess the feasibility of MRI using a mock scanner without any general anesthesia. And we want to describe the neuropsychological profile of CTD patients, first in comparison to sex and chronological age match controls, and second in comparison to sex and mental age match control. And then we would like to explore the ability of these new endpoints that we developed at the lab and validated on LC controls to capture the cognitive abilities of CTD patients. Then we did have 3 additional ancillary objectives. The first one was a neuroimaging study, including spectroscopy, structural, functional MRI, and I will let you know later, but and I will show you some images. We are able to include patients and sex and chronological age match controls. We also did want to perform a cardiac assessment. As you know that Levin et al. In 2021 described some cardiac characteristics on US patients. So all the patients up to now have accepted to participate in the cardiac assessment. I strongly encourage them to do so with ECG, cardiac echography, and 24 hours Holter ECG. Then we also created a collection of biological samples associated with clinical and genomic data from CTD, with blood and urine sample and fibroblast accessible to all researchers that want to work on these samples. So patients, as you know, we will include 24 male CTD patients aged 5 to 35, and each CTD patient will be matched to a chronological age match control and to a mental age match control. So 24 age match controls, chronologically age match control, and 24 mental age match control. So then we also did want to have additional typical developed children included for the outcome measures that we developed, just to increase a little bit the sample size of the number of patients children that were already included. So the main study of the 24 CTD patients is to compare their abilities to sex, chronological, and mental age match controls. Then you have the 3 ancillary studies that I just mentioned. And the subgroup of 9 patients participated to the longitudinal study with 2 additional on-site visits visit 3 and visit 7, and 4 additional online visits, visit 2, 4, 6, oh, there is a mistake, 5 and 6 over 3 months, with 7 visits in total. So it goes this way. So here you have the pre-inclusion. So it does not work. Okay. Too bad. So the pre-inclusion visits, and then the patients and families, they spent 2 days in Lyon because it was monocentric, and then the 9 patients came several times with the asterisk, the little star. It was on-site visit, and the rest was online. So we did assess a lot of different endpoints because the philosophy of this trial was really to have as many data as we could have, and then to decide what are the good outcome measures. So first we had clinical endpoints, parental questionnaires, and the families did a wonderful job to assess all the questions and answer all the questions. Yeah, I see some smiling face. They know what they did, so thank you. Then we did have cognitive CTD patient assessment, language assessment, motor assessment, social assessment, plus the 3 ancillary endpoints. I just cannot present all the data in 25 minutes, even if I'm speeding up a little bit. So I will have to make some choices. Please forgive me. So up to now, we have already included 14 CTD patients. So 14 male CTD patients having a pathogenic SLC6A8 variant. And the study started mid-March 2023. 9 of them already participated in the longitudinal study, and there is only 1 left patient who have already performed visit 1, 2, 3, 4. So it's the longitudinal study is almost done. The mean age of the patients was 17 years, coming from 10 to 25, and the age of the first symptom was quite soon, 12 months. The age at diagnosis was much later, 7 years. So regarding the clinical endpoints, I already mentioned that we did a very thorough developmental trajectory with the family and medical history. The epilepsy, I told you about it this morning. Physical examination, including walking, balance, especially. We defined with each family a symptom, a target symptom that they could rate, and they could rate repeatedly in order to check if it could be reproducible or if it could fluctuate, just because, as Andreas just showed you on images, it can fluctuate without a real treatment, so it was interesting to know that. Then we had actimetry. I don't know if you are familiar with actimetry. It's like it looks like a watch, and the patients had to wear it on the wrist of the non-dominant arm. It did go well, really, and then the beauty of it is that you can have it in ecological condition, meaning that you can wear it when you are at home in your usual environment, so that's interesting. And then what we can do is to describe the habit. In pink, you can see the period of sleep, and in blue, you can see the period of activity. So it's a very good way to assess the time of sleep. So for example, we analyze all the patients, and the mean latency of sleep was 25 minutes. The total sleep time was 7.5 hours per night. Of course, it's over the 14 patients. And what was interesting, and I have not come back to the families yet to explain individually this result. The rest, yes, but this result, no. So please forgive me, I will come back to you just to explain, because some patients had a wake after sleep onset, and it's quite interesting to quantify it and to see, because some of them had quite a lot of awakening during the night, so it might be also interesting to look at that. And then during the day, so this is just the activity during the day, and you can see there are several blue lines. And basically, because of we had a podometry included in the actimetry, so we were able to quantify the level of activity of the participant. So was he doing a lot of activity, less, with 4 graduation. So then we had a 6-minute walk test and the feasibility of performing the MRI. So on the MOX scanner. So here is the MOX scanner. So all these pictures are the MOX scanners. So it looks like the real one. And the families were wonderful because they really participated well with us and tried to understand what could be an obstacle for the patients. So right now, out of the 14, only 12 of the 14 have done the last assessment with the neuroimaging study. And out of the 12, 9 were able to perform the MRI. So it was kind of really unexpected for us because up to now, it might change, of course, but up to now, and without selecting at all the participants, we were able to perform 75% of MRI with very good quality data. One of the things so I review and we analyze the data clinically with myself as a child neurologist plus a neuroradiologist, Professor François Coton. So we did review all the images. And as you can see here, most of them had a very slight atrophy, so it's interesting to describe that, and we will quantify it, of course. Then they were able, and the 9 patients were able to perform the 3DT1, but also the 3DT2 flare sequences, long and short echo on basal ganglia and white matter ganglia regarding the spectroscopy, diffusion imaging, and resting state. So it's quite it was kind of impressive, and again, congratulations to all the patients that participated. So collaboration with Andreas Schulz, we use the same, he just showed you his protocol regarding the area of recording for the spectroscopy. So we did do the same thing in order to be able to compare the data afterwards. So here you can see the spectroscopy, and you have seen a lot, so you're very familiar with it. But basically, the region of interest is in the basal ganglia, and you can see in a healthy control the wonderful peak of creatine here. And then, of course, the same thing in the patients where we have a very small creatine peak. So then we did the same thing in the white matter, short echo. And then we used, and in collaboration with Hélène Ratinet, I work with a Sequest, which is one of the modules of the MRI tool that allowed us to be able to analyze more quantitatively the spectrum of spectroscopy. So you can see in black, the actual original data, and then in green, the fitted model. So it did go quite well, and we were able to quantify phosphocreatine and creatine and computed the total creatine. And as you can see, without any surprise on this, the controls had higher creatine quantity. That's not a surprise. But what was more a surprise, and it seems it's just a trend, and we'll see if it is confirmed or not. But as you can see here, it seems like the higher the peak, the residual peak of creatine is, the higher the peak is, the higher the IQ is using the lighter scale, which was kind of a surprise. We did not know if we could find that. So that was, I think it's interesting, but needs to be confirmed on more patients. Then I already told you about lighter. So all patients were able to have an IQ, and you can see that it came from 39 to 75. They were also able to perform the progressive matrices, but using this little uncastrable way. So it's like a puzzle, and you have to fit, and you can try several times to find the right option. So the mean mental age was 4.5 years. It's important because it's the measurement that we use to match with the LC controls. Here are the violence scale, you know that, and they were, of course, better on receptive than expressive and better on domestic than personal regarding the daily life. So what was very important for us was the 4 simple reasoning tasks on tablet that we developed. So first, there is a match to sample task, the categorization task, implicit rules learning task, and matrices task. So what is interesting is that it represents 4 levels of increasing difficulty, and that was very clear on the error rate and the capacity of the patient to participate to all of them. So here, an example of the first. So it's just using Disney character to familiarize the participant and to help the person to understand that he has to find the one who is the same as the one above. Then, so you have 2 different conditions. The matching condition, when you have to find the neutral response, is totally different from the target, and the inhibition condition, when the false response looks like the target, so you have to inhibit the fact that the similarities. So here it comes with picture that we design in order to be able to use them without any problem. So you see it goes kind of well, but now I know that you are expecting the results of the patient. So we validated this task on 100 participants, and as you can see here, we found a significant inhibition and group effect. So it's children 3 years to 10 years and adults. And of course, there was an effect on the age on the reaction time. And on error rate, we find a significant inhibition and group effect. And as you can see here, it was really the youngest children that made the most mistakes. Here are the results on 14 CTD patients. So what was first very interesting for us was the fact that even the most severely impacted participants were able to do this simple task, which was good news for us, at least. So here you can see the level of error. So the mean error rate was 18%. So what is interesting is that it seems, of course, the LC controls, we only have included 3 up to now. They did 0 mistakes because this task is very simple. But what matters is that we were able to quantify the ability of the patient to understand the concept of the same. Then the categorization task. So this time you do not have to find the same. You have to find the one who goes well with the picture of above. So basically, here you have to find the close. And the false response is totally different from the target in the simple condition, whereas in the difficult condition, it is closer. So basically, the false response being closer to the targets makes it more difficult to find the right answer. So again, very simply, on the tablet, and you just click. And in order for them to get, to keep going, when you find the right answer, it moves, it turns around. So it's kind of nice. Then, so again, we validated on more than 100 participants, and we find again a significant difficulty effect and group effect according to the age. And on the error rate, we find a very nice difficulty effect and group effect. So what we did also was to develop 2 versions of this task in order for us to test and retest the participant without being too boring, seeing the same pictures. So you can see that it was very stable between both versions in LC controls. So very good test, retest, reliability. Here are the results in 14 CTD patients. So you can see that they are making a little bit more mistake, roughly 30% of mistakes for this task. But what is interesting is that we can quantify their ability to categorize without asking them to be able to say the category. So that was very important. Then, inspired by the Brixton test, we developed this test where you have this black circle that moves and you have to predict where it's going to go. So we warn the participant that the rules can change during the test, and it looks like this. No, it doesn't work. I don't know why. Does not matter. Basically, the first rule is to go from one circle in the right the right direction, and then in the other direction, and then one out of two, and then one way, the other way, one out of three, and it's getting more complex. So, of course, the youngest, all the children aged 3 and more can perform the simplest rule, which was very important for us. Then we did check the maximum level of rules acquired by the participant, and this concerned only 11 patients out of 14 were able to do this test. What is interesting is that it's quite conservative, because in order for us to say that, for example, the +1 rule, it's validated only if they put their finger on the right answer immediately. If, for example, they check and find it, but not immediately, it does not count. So you can see that for the first rules, more than 80% of participants were able to find them. What about the online visits? Here you can find what it looked like. So this is a CTD patient performing the online on Zoom connection. So you can hear birds from his home, but it's going very well. And what was interesting too was the fact that regarding the 9 participants that performed the 4 first visits, you can see that it is very stable around the different visits. Regarding language assessment, we use the PPVT5, and basically it's show me the picture corresponding to get dressed. So you have to show what picture it is. And then all patients were able to perform this task with a lexical age in designation, so receptive language, around 5.5 years. And then the equivalent, but this time on expressive language, only 12 participants were able to do it. And the question is, what is this? And they have to answer, it's a tree. Then the lexical age was slightly lower for the group, around 5 years of age. So regarding the motor assessment, just because I did... Sorry about the sound. Basically, it was the 2 different conditions. So we had 4 different conditions. So we had two sides of the object, and then the participant had to take it and to put it either in a very large hole, so it was easy to do, or to fit it precisely in a smaller hole. And you can see here that what is interesting is that it's data on the 11 participants that are accepted to do it, and you can see that they managed to adapt their pinch for grasping to the size of the object, which is a good thing. and then what is also very interesting is that because they have to grasp the object and to take it to the further hole, and they have this impact on the second part of the motion that is impacted by the size of the hole. I will just show you the social scenes, because all the participants were able to perform the eye tracking task that we designed, and that was validated on 40 participants. And you can see, so it was pictures with people that interacting one with the other, and other very interesting details, but non-social. And then we computed the time that they spent on social versus non-social items. And the last eye tracking task was this time to view at the same time 2 clips side by side, one social, the other non-social, and to look at the time they spent on each videos. So it's interesting because it's very simple, and it helps us to have a good idea about their social appetence to look at the social video. And as you expected, I mean, even more younger children were very attracted by the social, in blue, the social area. So to conclude, these new outcome measures, we think that we were adapted and appropriate to assess ID patients with different difficulty levels, which is important in this disease. This provides objective and quantitative assessments. To perform that on tablets, including carried out at home, is no problem at all. And eye tracking is interesting because the participant is simply asked to observe the screen and does not have to do something by sea. We think that it could be a useful biomarker in future studies on CTD. And of course, I would like to thank all the families that came to Lyon, and we did have a great time, I think, even if it was kind of busy days sometimes. And I would like also to thank all my collaborators, especially Angelus, the engineer that works with me, Farah, and Marion Buchy. Thank you for your attention.